Thank you again, everyone, for joining us tonight. Good evening to all of you. Thank you so much for joining us for the second event in our ongoing series, Emerge. I'm Maggie Harrington from Morphin Australia, and I'm really excited to open up our session for tonight as we have a lot of really great material to cover. So the focus of tonight's session is ROTEM in trauma, and before we get into it, I just want to take a moment to touch on the purpose of our Emerge events. So Emerge stands for Education Meetings for Expanding ROTEM Guided Excellence. And the aim of this series is to highlight evidence-based best practices for improving outcomes for critically bleeding patients. The core focus of these sessions is to harness knowledge transfer of ROTEM-guided patient blood management strategies to enhance patient safety, optimize resources, and reduce costs. Now, before we settle into our program for tonight, I just want to quickly touch on some housekeeping items. The first of which is our survey. So your feedback is crucially important in developing the content of our future events. So please be sure to fill out the survey that we'll provide to you via email after the event. Next, just on to mention some technical details of this Zoom session. I do want to let everyone know that this meeting is being recorded. And additionally, for anyone who joined our previous meeting, I just want to clarify that the format is a bit different in this session from the last time, as tonight we do have the functionality to see you and to hear you if you so choose. So we would like to save all of the questions and discussion for the Q&A session at the end of the meeting. So if you have any questions along the way, please feel free to pop them in the chat. And if you prefer to ask your questions live out loud rather than typing them out, just indicate in the chat that you have a question and we'll be sure to call on you during the Q&A. Of course, we'll do our best to answer all questions live during the event, but for any questions that we just can't get to due to time restrictions, we will be sure to publish a list of questions and answers in an email following the event, just like we did last time. I also want to quickly let you know that we have some interactive cases as part of tonight's presentation for which you'll be prompted to answer some poll questions. So the poll responses are completely anonymous. Don't worry about getting the answer right. We just really want to encourage everyone to participate as a learning opportunity. So when the poll question pops up, you should have the ability to move the box over to the side of your screen. If you've connected to the meeting with your phone, you probably won't have the ability to move the box aside, so we just wanted to give you a heads up about that. But we will keep the poll questions on the screen for about 30 seconds before removing them and showing the results from the group. So next, moving on, I'd like to introduce our fantastic Morphin Australia team. First, from Brisbane, we have Craig O'Sullivan, who's the product manager for our acute care diagnostics product line. Also in Brisbane, we have Natasha Curie, acute care diagnostics clinical specialist who covers the ROTEM training and education across Queensland. Next, from Perth, we have Julia Bonzer, also an acute care diagnostics clinical specialist. And Julia looks after ROTEM training and education in Western Australia, the Northern Territory, South Australia, and Tasmania. We also have with us tonight Kieran Pickles, our National Sales Manager, and Peta Samaras, our Acute Care Product Specialist, both of whom are based here in Sydney. And we have Azadeh Zargari, our Systems Specialist, who is actually relocating imminently to Victoria. And Azadeh will be looking after the ROTEM training and education across Vic. And once again, I'm Maggie Harrington. I look after the ROTEM training and education in New South Wales and the ACT. And now I'm excited to introduce our amazing guest speakers. Joining us tonight is Dr. James Winnerls, Staff Specialist in Intensive Care Medicine at the Gold Coast University Hospital. Dr. Winnerls trained in the UK, South Africa, and Australia, and has been an intensivist at GCUH since 2012. His special interests are in cardiothoracic intensive care and the coagulopathy associated with critical bleeding. The GCUH Critical Care Research Group has an extensive program of research investigating the utility of point-of-care testing in critical bleeding, and also the FEISTY study, a clinical trial studying the effects of rapid fibrinogen replacement in severely injured trauma patients. Tonight, Dr. Winnerls will be sharing some insight into management of traumatic hemorrhage at his institution, while also discussing some of his research endeavors and sharing some really interesting case reviews with us. Next, joining us again is Dr. Klaus Gorlinger, one of the leading international experts in the management of coagulopathy and hemostatic resuscitation. Dr. Gorlinger has over 26 years of experience working as an anesthetist, intensivist, and hemostasiologist at the University Hospital in Essen, Germany. And his main passion of research is the development and implementation of points of care guided algorithms for goal-directed perioperative bleeding management and patient blood management. Tonight, he'll be sharing some of his expertise with us, as well as digging into interpretation of the iTactic study. So without further ado, please welcome Dr. James Manurles and Dr. Klaus Gorlinger. Thank you so much to both of you for joining us tonight, and over to you, Dr. Manurles.
Thank you very much for having me. Much appreciated. You have to bear with me. I'm not technologically very competent, and I'm sitting on my deck here in Brisbane, Queensland, with about 1 million children and dogs and cats running around. So if there's a little bit of a disturbance, please bear with me. I'm just going to share my screen with you now. Hang on a second. Can everybody see my screen?
Yes, it's fine.
Yes.
Perfect, thank you. Okay, so thank you very much for inviting me to be part of this session, and it's a great honor to be presenting to you today, and also a great honor to be presenting with Klaus as well. Klaus is obviously a world-renowned expert in this field, and I've certainly learned a huge amount from his vast breadth of knowledge. So just a quick thank you to Klaus for everything that he's helped me with and helped us with at Gold Coast University Hospital. So we're going to be talking about VHA guided transfusion, specifically in the trauma patient population. We're going to talk a little bit about why we do it, a little bit about how we do it at the Gold Coast Hospital, and touch on some of the evidence surrounding viscoelastic hemostatic assay testing and guided transfusion in the trauma patient population. Certainly in the trauma patient population, the assessment of coagulopathy pretty much came to the fore almost 17 or 18 years ago with Karim Brohi's very good basic science experiments and clinical studies suggesting that there's a concept of an acute traumatic coagulopathy that is associated with severely injured trauma patients. It's unique to trauma patients, and it's present before large volume fluid resuscitation and large volume packed red blood cell transfusion. Identified that in up to 40% of severely injured trauma patients, there is this entity of this acute traumatic coagulopathy or trauma-induced coagulopathy that is associated with a significant increase in mortality. The full mechanistic understanding is not entirely clear, although there's been a lot of work done in the last 15 to 20 years trying to understand the mechanisms. I'm not going to talk too much about the mechanisms. It's essentially a balance between the procoagulant and the anticoagulant pathways that are disrupted by the presence of severe trauma. So it's a direct tissue injury, a hypoperfusion, and an endogenous process that is driven by the inflammatory response associated with severe trauma, not just like we were all told when we were back at medical school, it's a consumptive or dilutional coagulopathy. And essentially the key clinical features are systemic anticoagulation, hypo or dysfibrinogenemia, platelet dysfunction, and fibrinolysis. Now, in response to this identification of this acute traumatic coagulopathy, which then goes on to exacerbate major hemorrhage and severe trauma, there was development of major hemorrhage protocols. Now, these major hemorrhage protocols have been designed to prevent and treat traumatic induced coagulopathy, to prevent the unopposed transfusion of multiple units of packed red blood cells without coagulation factors. There's absolutely no doubt that they have improved survival and they form an integral part of damage control resuscitation. The majority of major hemorrhage protocols were initially designed and developed from the recent military conflicts in Iraq and Afghanistan, and they've been translated into the civilian arena, not just in trauma, but also in major GI hemorrhage, vascular surgery, cardiac surgery. Having said that, the ratio of blood product transfusion remains particularly controversial. One of, I think, the major things that we just have to touch on with the major hemorrhage protocol is not so much the delivery of blood and blood product that has improved survival. I think it's a whole team thing that rapidly escalates or activates a team of highly specialized ED, trauma surgeons, vascular surgeons, anesthetists, intensivists to be there on arrival for the most severely injured trauma patient and make sure that the system to get those patients to the operating theatre or the interventional radiology suite for control of hemorrhage in a timely fashion has probably made a significant impact on mortality and the survival benefit, rather than just the rapid delivery of blood products. So in the past, they were called massive transfusion protocols, and I think I prefer the term major hemorrhage protocol, which essentially is a protocol that is designed to stop bleeding and support the coagulation system at the same time. Major hemorrhage protocols have evolved dramatically over the last 5 to 10 years. With now the majority being relatively high fixed ratio major hemorrhage protocols, utilizing 1-to-1 ratios of packed red blood cells to plasma to platelets. The evidence surrounding the use of a 1-to-1-to-1 transfusion ratio does remain controversial. I'll touch on that a little bit later. As our understanding of the coagulopathy of trauma has evolved, it has become clear that it's not a one-size-fits-all matter, and certainly certain patients have different disorders in their coagulation system that are contributing to their ongoing bleeding. Now, we're pretty good at identifying patients that are bleeding in front of us. I mean, patients, you can see it, it's either on the floor, in the belly, or in the chest. What we're not quite so good at identifying is those patients in which coagulopathy is contributing to ongoing bleeding. So what we really need to do is to try to identify coagulopathy and which components of the coagulation system are dysfunctional at that particular time. There are really two major camps, I think, with respect to the approach to the major hemorrhage protocol. The European approach, which very much favors a tailored hemostatic approach using specifically viscoelastic testing to identify coagulation deficits and treat each individual one individually. And again, that's probably coming more into the play in the Australian system as well. And certainly at the Gold Coast, we very much utilize a viscoelastic guided approach to our major hemorrhage protocol and severe trauma. The other camp would be the fixed ratio 1-to-1-to-1 transfusion. And I don't think that you can argue now that either one is better than the other one. There's a lot of evidence out there, none of it particularly high level. And Klaus is going to touch on a little bit of that in his later talk. I think whether you're choosing to do a 1-to-1-to-1 ratio or a viscoelastic targeted guided transfusion protocol is whatever system works for you in your hospital with the resources that you've got available to you. As we said, when we're trying to assess the components of the coagulation system, what we really need is a test that's going to give us very quick results. It's going to individualize to each individual patient, relatively inexpensive, and probably easy to perform in the point of care environment. So what do we have for that at the minute? Standard laboratory test, or the classic definition of a coagulopathy associated with trauma, would be an INR of more than 1.2 to 1.3. We have to understand that the standard laboratory tests, whether they be the INR, the PT, the APTT, these were not tests that were designed to assess complex multifactorial coagulopathies. These were tests that were designed specifically to monitor effects of exogenous anticoagulation, and they don't give any information on the clot strength or the breakdown of the clot. And there's no evidence that standard laboratory tests are useful really in any way to guide transfusion, especially in the major hemorrhage setting. The most important issue, I think, rather than the necessarily the way these tests were designed, is the turnaround time to get result availability. We've demonstrated in our institution There's a significant time delay to availability of standard laboratory tests, and this is borne out in a number of studies, specifically suggesting that the availability of these results can be upwards of 60 to 90 minutes. And certainly that is not going to be useful, because these results are going to be historical by the time that we administer any therapy, and give no true representation of what is happening at each individual particular time during the time course of the resuscitation. So if we need another test in which we're going to assess coagulopathy, excuse me, sorry, what about viscoelastic hemostatic assays? Now, the technology is not new, been around since the 1950s. And the two major devices out there are the TEG and the ROTEM. I'm not going to discuss the differences or the pros and cons of each individual device, but needless to say that the classical thromboelastography is based on the pin and cup technology, where a small aliquot of citrated blood is placed in a pin and in a cup, and a pin is rotated around an axis. And as the clot forms, causes impedance to movement of the pin, and this is then graphically and numerically represented on a computer screen, giving ideas of time to clot formation, the strength of the clot, and the stability of the clot over time. So these devices do give you significantly more amounts of information than you possibly get from a standard laboratory tests. At the Gold Coast, we specifically used the ROTEM device. We initially started with the manual pipetting device, and we've now moved over to the fully automated ROTEM Sigma device. And in a sense, the technology is very, very similar to the ROTEM Delta device, using the same reagents, but removes the possibility of intra-operator variability by removing the possible flaws associated with pipetting technique. Giving you information on specific hemostatic defects, specifically hypofibrinogenemia, coagulation factor deficiency, hypofibrinolysis, and platelet dysfunction. This slide just shows a graphical representation of what a classic thromboelastometry image will be demonstrating as the clot forms over time. So as you can see at the beginning of the trace, there's the CT in the green, and this is the initiation of the clot. This is the time for the clot to first form, and this is measured in seconds. Over time, once the clot has formed, there's amplification of the clot, as you can see in the pink section of the temogram. And as the clot develops over time, the interaction of platelet, fibrinogen, factor 13 will give you an indication of the strength of the clot, or the maximum clot firmness. We don't wait in our algorithms for maximum clot firmness. We use the surrogate markers of clot strength or amplification at the A5 or the 5 minutes after clotting time to give us an idea of the clot strength. And then as the clot either breaks down or remains stable over time, gives you an indication of whether this patient is suffering from fibrinolysis. I'll just talk briefly about the two major tests that we use in our trauma patient population, which is the XTEM test, which would be essentially to liken it to the extrinsic clotting factors that we're classically all known about and been taught about at medical school. This is a calcium chloride activator with recombinant tissue factor, and the clotting time, or the CT, gives you an indication of the presence or absence of adequacy of clotting factors. The clot amplitude, either at 5 minutes, 10 minutes, or maximum clot firmness, gives you an indication of the fibrinogen and platelet interaction towards clot strength. So if you've got a reduced clotting amplitude in your XTEM test, i.e. your maximum clot firmness or your amplitude at 5 minutes is low, in the setting of a normal FibTEM, one can deduce that there's a poor platelet contribution to the strength of the clot. If, having said that, your clotting time is extended, or you've got a long clotting time, again in the setting of a normal FibTEM test, this would suggest that there's possibly either a factor deficiency or the presence of anticoagulants. As I alluded to in the previous slide, the FibTEM is the other test that we use. This is exactly the same as the XTEM test, again using the calcium chloride and the recombinant tissue factor. but the contribution of platelets to clot strength or propagation is removed by the addition of cytokinase D. So it's essentially exactly the same as the XTEM test, but without the contribution of platelets. Again, so the amplitude, either at 5 minutes, 10 minutes, or the maximum clot firmness, is giving you an indication of the fibrinogen contribution to your clot strength. And a reduced clot amplitude in the FibTem test would suggest that there's a fibrinogen deficiency. And there's been a number of large scale observational studies looking at many thousands of patients, both using TEG and ROTEM, suggesting that the TEG and the ROTEM data is just as valid, if not more valid, and clinically superior to the rapid identification of acute traumatic coagulopathy than standard laboratory tests. Some people still refute this, and a couple of trauma centres use the rapid point of care INR testing, and they found that this test is potentially cheaper than TEG. It's available just as quickly and may give you some idea if the patient is coagulopathic. But you have to remember that if the prolonged INR only gives you one snapshot of the coagulopathy of this patient, i.e. time to clot initiation, doesn't give you any idea of clot strength or clot stability over time, or the indication of whether fibrinogen or platelet deficiency may or may not be present. Despite all of the observational data, there's relatively limited high-level randomized controlled trial data to suggest whether TEG or ROTEM strategies can be utilized in terms of positive patient outcomes. And I think the most common take-home point is that we can use these devices to absolutely identify coagulopathic patients. There is certainly evidence to suggest that they reduce morbidity and mortality in terms of transfusion requirements, but there's not a definitive signal for increased mortality associated with VHA testing. Having said that, more recently, there's been a couple of recent trials that have either been recently completed, comparing specifically VHA testing to standard laboratory testing. This trial was performed in a North American trauma center, suggesting that a TEG-guided major hemorrhage protocol in civilian trauma patients results in a significant survival improvement compared to a major hemorrhage protocol utilizing standard laboratory tests, and more importantly, utilizes less plasma and platelet transfusion. And I think that's one of the other important things that we have to remember with these viscoelastic testing, is that although they can identify when a patient may require a product, probably just as important is to identify those patients that don't need a product. The less that we can expose these patients to allergenic blood products, the better it is for them. So it's not just identifying patients that require a blood product transfusion, but it's identifying patients that don't require blood product transfusion to avoid unnecessary transfusion. This again is a single center clinical trial performed in Brazil, again comparing a standard major hemorrhage protocol to a VHA guided transfusion protocol. It's completed recruitment, but hasn't as of yet published its results. Now, I think the one that we all know about that's recently been published by Karim Brohi's group in the UK, the iTactic group. This is a randomized control trial comparing a VHA guide augmented major hemorrhage protocol to a standard laboratory test augmented major hemorrhage protocol. It's recently been published. The outcome or the conclusion in this particular paper was that there was no overall difference in outcomes between VHA or standard laboratory test augmented major hemorrhage protocols. I'm not going to talk too much about this particular study because Klaus has got a very, very good presentation on it that goes into a lot of detail. But the one take-home message I will say from this particular study was that this was not comparing a pure VHA-guided major hemorrhage protocol to a non-VHA guided major hemorrhage protocol. These were patients that were enrolled. Their major hemorrhage protocol with a 1-to-1 transfusion ratio was initiated at trauma unit arrival, and subsequent therapy was then guided by either VHA or standard laboratory tests. Now, that's a key difference to the way we manage the patients at the Gold Coast, and is a difference to a lot of the European trauma centres, where a one-to-one transfusion ratio is not standard practice. It's rapid identification of coagulation deficits using VHA testing and replacement of product as required. As I said, I'm not going to go into a huge amount of detail because Klaus has got a very good presentation, which will go into much more detail later. And going back to specifically the 1-to-1-to-1 versus the 1-to-1-to-2 ratio, we can't really ever talk about transfusion in trauma without discussing the PROPER study. The PROPER study was, to date, the largest civilian trauma patient population transfusion trial, specifically investigating whether a high fixed ratio 1-to-1-to-1 of packed red blood cells to plasma to platelets was superior in terms of mortality compared to a lower ratio transfusion major hemorrhage protocol. Now, this was a very impressive study, enrolled almost 700 patients, 350 odd in each group. Having said that, they did not demonstrate a statistically significant survival benefit for a high ratio, either 1-to-1-to-1 compared to 1-to-1-to-2, as a statistically significant outcome at the end of the trial. Despite that, what I think you can see from these two pictures I put on the bottom here is that there's a very, very clear separation in the mortality very, very early on in these patients. There's a definite survival benefit in those patients early on randomized into the 1-to-1-to-1 group. This is continued throughout the enrollment period, but unfortunately did not reach statistical significance. Now, I think what the key take-home point from that is that whatever we do, whether it's a 1-to-1-to-1 or a 1-to-1-to-2 or a VHA, we have to do it early. We have to do it within at least the first 1 hour of presentation of these trauma patients to the emergency department. So can we do that with a fixed ratio major hemorrhage protocol? Certainly in my institution, we don't have fresh frozen plasma stored in our trauma bay. It would take us at least 45 minutes to receive fresh frozen plasma, even if activated as part of a major hemorrhage protocol. And this is borne out in a large study looking at all the major trauma centers in the United Kingdom, where time to first fresh frozen plasma transfusion was, in those patients with massive hemorrhage, was 67 minutes, up to 87 minutes in those patients with major hemorrhage. So that's well over an hour to receive your first coagulation support in these patients with massive hemorrhage. And as we saw from the previous slide, it's that first hour that is absolutely key to get on top of coagulopathy in an attempt to stem bleeding and allow time to get to the operating room for surgical control of hemorrhage. And in the PROPER study, as I said, suggested that they can their response time for activation or to receive their plasma and their platelets was within 10 minutes of arrival to the trauma center. And that's because they've got a very high volume of severely injured trauma patients, and they can keep plasma and platelets in their trauma bay 24 hours a day, 7 days a week. And certainly I think in Australia, that's not feasible in terms of wastage. We do not have the volume of trauma to be able to support that product availability. Additionally to that, a number of studies have suggested that even if you do achieve a 1-to-1-to-1 ratio, which is very difficult to do in a timely manner, that it does not actually appear to correct your coagulopathy. It doesn't get it better. It may prevent your coagulopathy worsening, but it certainly does not correct your coagulopathy to normal levels. And a number of observational studies, mostly from the European groups, have suggested that an early exclusive use of factor concentrates that are rapidly available in the trauma bay can result in improved outcomes in severely injured trauma patients. One of the randomized controlled trials I would just like to talk about briefly was the RETIC trial. This was the reversal of trauma-induced coagulopathy using coagulation factor concentrate, specifically fibrinogen concentrate and prothrombin in comparison to fresh frozen plasma. Unfortunately, this study was recruited over quite a number of years and quite slowly, and was unfortunately stopped early due to an interim analysis that suggested that there may well be harm in those patients that were randomized into the fresh frozen plasma group. And then what the take-home message from this study is not necessarily the coagulation factors per se, but the early and effective fibrinogen supplementation, specifically using factor concentrates, appears, I say, to be beneficial in terms of patient outcomes. Unfortunately, as I said before, the study was ceased recruiting before it could reach its full target sample size. So unfortunately, we do have to interpret these results with a little bit of caution. But the story is no different really for plasma compared to coagulation factor concentrates, as is borne out by these two recently published papers looking at pre-hospital plasma in the United States. The PAMPA trial suggested that the pre-hospital administration of plasma reduced early mortality, or lower 30-day mortality, than those that were just transfused packed red blood cells and intravenous crystalloid fluid resuscitation. And published just about a week later in The Lancet was the pre-hospital plasma trial that suggested that there was no survival benefit associated with pre-hospital plasma transfusion in a severely injured trauma patient. The difference between these two particular studies is that one was an aeromedical transport and one was a ground transport study. So for my mind, I think that certainly if you've got a long transport time to hospital or to definitive trauma care, there certainly may well be a benefit in coagulation factor support, whether that be with plasma or whatever factors are available to you. Having said that, if you've got a rapid transport time to hospital, delaying your transport time to hospital to give coagulation factors is not beneficial, because what these patients are going to die of is major exsanguinating hemorrhage. All the coagulation factors in the world are not going to make a difference to that. You need to get them to definitive surgical care. The European Trauma Guidelines, which I think is now in its 4th or 5th iteration, consistently does suggest, though, that we should be using early and repeated monitoring of hemostasis. And certainly the evidence is I think, probably now there to use viscoelastic testing in terms of speed, accuracy, and the amount of data that you can get from these. And I think that to do a major hemorrhage protocol without monitoring your coagulation is no longer acceptable in this day and age. So how do we use the numbers that we get, and what numbers do we use to decide what we should be treating and when we should and when we shouldn't be treating? And that's been a huge amount of work from the tactic investigators in the UK, where they've looked at at least over 2,000 patients using both TEG and ROTEM and standard laboratory tests to identify cutoffs or transfusion triggers for replacement of products. And we've certainly based our algorithm not just on our own experience, but the experience from the Northern Europeans, and then based on this data that's recently come out from the tactic group. And this again suggesting that fibrinogen replacement, whether you're using ROTEM, TEG, or standard laboratory tests, with a FibTem amplitude of less than 10 millimeters, you need to give fibrinogen. If your XTEM amplitude is low, you give a pool of platelets. If you've got a normal XTEM amplitude, as I mentioned earlier, but a prolonged XTEM clotting time, you need to replace factors with plasma. And if there's evidence of fibrinolysis or clot breakdown, give additional tranexamic acid. Certainly in our institution, we do give tranexamic acid up front, without necessarily waiting for ROTEM tests. But if we see ongoing evidence of fibrinolysis, we will give additional tranexamic acid. And this was just a little review paper that we published recently, suggesting that the optimal transfusion strategy for severely injured trauma patients is such a controversial and diverse topic, and there's enormous institutional and geographical variation in practice. But neither way you can say is definitively right or wrong. And as I said earlier in the talk, is that whatever your institution is comfortable with, or the logistics of your institution permits, that's what you should be using. So I'll just talk briefly, if that's okay, just about the algorithm that we have at the Gold Coast University Hospital. This is probably about the 9th or 10th iteration of our algorithm. And we've used data from overseas, we've used institutional data and looked at other people's published algorithms. And again, I can't thank Klaus enough for his guidance in the development of our treatment algorithms. And basically we go through a stepwise identification of coagulation deficits. We will perform a ROTEM test on arrival to the emergency department. We will not delay transfusion of packed red blood cells. Those will be given or found in the laboratory. Packed red blood cells will be dispatched as part of the major hemorrhage protocol. But coagulation factors, the majority of the time will be replaced in a stepwise manner, depending on what the ROTEM test demonstrates. Now, clearly, if you've got hyperfibrinolysis, so you've got a flat line in your FibTem, or evidence of clot breakdown in your XTEM test, we would suggest giving very early fibrinogen concentrate and tranexamic acid simultaneously. These patients, civilian trauma patients that present with a flat line, if you would, or no evidence of either clot initiation or clot propagation in their fibrinogen test, will require early upfront fibrinogen replacement in conjunction with tranexamic acid. There's no time to waste for these particular patients because these are the ones that are most severely injured and are exsanguinating in front of you. Again, if you then go down to the stepwise, once you've treated your urgent hyperfibrinolysis and your profound hypofibrinogemia, we're looking more in depth at the fibrinogen. And we've picked a FibTem A5 amplitude of less than 10 millimeters. And this would correspond, I think, to about a Klaus fibrinogen of 2 grams per liter, or a TEG functional fibrinogen maximum amplitude of about 20 millimeters. And we would suggest either giving fibrinogen concentrate or cryoprecipitate, depending what's available to your institution. I'm going to talk a little bit more about fibrinogen a bit later in my talk. Only once you've corrected fibrinolysis and fibrinogen, we then look at the platelet contribution to clot strength, and then subsequently looking at the factor contribution to clot strength. Certainly in our experience, quite often you'll find prolonged XTEM clotting times in the setting of hypofibrinogenemia that will correct with fibrinogen replacement alone without the requirement for clotting factors. And as I said previously, one of the key things for the viscoelastic testing is to be able to identify those patients that don't require a factor replacement to avoid unnecessary transfusion. So I'll just talk a little bit more about fibrinogen specifically. A crucial coagulation factor synthesized in the liver, both in primary and secondary hemostasis. It's the coagulation factor that circulates at the highest concentration in the blood circulation, and certainly in severe trauma is usually the first factor to fall below critical levels. So if fibrinogen is so important, what tests do we use to identify hypofibrinogenemia? What is the optimal product for fibrinogen replacement, fibrinogen concentrate or cryoprecipitate? And what is the optimal dose of fibrinogen replacement? It's a very controversial topic. There's very limited high-level evidence. And again, there's widespread variation geographically, individually, and institutionally in terms of practice, and very limited guidelines in the international literature to guide how we replace fibrinogen and with what. Regardless of what we use to replace fibrinogen, the evidence is certainly in there now that the importance of hypofibrinogenemia in severe trauma, and patients with hypofibrinogenemia and severe trauma certainly have worse outcomes, and probably at fibrinogen levels that in the past we may well have thought to be normal in ability. Hello, was that my computer? No. And recently published from the Australian major hemorrhage group, suggesting again that fibrinogen levels in severely injured trauma patients below the normal reference ranges is associated with significantly increased mortality. And again, the European trauma guidelines would suggest that if there is either viscoelastic evidence or standard laboratory evidence of hypofibrinogenemia, early replacement of fibrinogen, either using fibrinogen concentrate or cryoprecipitate, is mandated. There is little evidence, however, to compare and contrast the two products. And certainly in Australia, cryoprecipitate is the most widely available product to replace fibrinogen, whereas in a number of Northern European countries, cryoprecipitate is no longer available for use due to concerns of a viral transmission, and fibrinogen concentrate is the only method available to replace fibrinogen. There have been no direct head-to-head trials comparing, in terms of patient-centered outcomes, what is the most appropriate or superior product for fibrinogen replacement. One of the major drawbacks that we need to think about with cryoprecipitate is the time to availability of the product. Certainly, again, in our institution, it will be over an hour to receive cryoprecipitate from activation of major hemorrhage protocol. And this, again, is borne out from the previous slides that I showed with respect to fresh frozen plasma availability from a major trauma centers in the UK. It's well over 2 hours, even in patients with massive hemorrhage who are exsanguinating, to receive cryoprecipitate. And again, clearly, as we've said, fibrinogen is the key clotting factor that falls first. It's very important to replace fibrinogen because hypofibrinogenemia is associated with worse outcomes. If we're waiting for over 2 hours to replace our fibrinogen, we're certainly doing our trauma patients a disservice. Again, these findings were backed up with an Australian study, which was suggesting at least 2 hours to receive cryoprecipitate, even in severely injured trauma patients. In response to this, Karim Brohi and Nicola Curry's group in the United Kingdom performed the CryoStat-1 study. This was a small pilot feasibility study to assess the time to administration of cryoprecipitate as part of a major hemorrhage protocol. Patients were randomized into receiving a standard major hemorrhage protocol or a standard major hemorrhage protocol with early empiric delivery of cryoprecipitate. And they demonstrated that actually you could give it a lot quicker than was found in observational studies, with a median time to delivery of cryoprecipitate of 60 minutes. Having said that, that's still quite a long time if we're talking about that golden hour of hemostatic resuscitation. Subsequent to that, currently recruiting in the UK is CryoStat-2. I'm sure you've all heard about CryoStat-2. This will be, once it's finished completing, the biggest trial investigating severely injured civilian trauma patients, and is almost 3/4 of the way to recruiting. And this is going to answer a very important question, I think, about whether early fibrinogen supplementation using cryoprecipitate is effective in terms of mortality for severely injured trauma patients. As I said before, the time drawbacks associated with cryoprecipitate have led to some interest in assessing the use of fibrinogen concentrate in severely injured trauma patients. This is a Canadian study that suggested the early empiric delivery of fibrinogen concentrate was feasible and certainly results in an increment in your fibrinogen levels in severely injured trauma patients. This study used quite a large dose of fibrinogen concentrate, 6 grams, that was delivered in the absence of either standard laboratory test or viscoelastic evidence of hypofibrinogenemia. So although it can be given quicker, I think one of the things, the take-home message from this particular trial is that over half of the patients that were enrolled were in fact not hypofibrinogenemic. So potentially giving patients who are not hypofibrinogenemic 6 grams of fibrinogen concentrate may be detrimental. And I think that's why we're using these viscoelastic testing to rapidly identify those patients that either benefit or would not benefit from fibrinogen replacement. In contrast to the Canadian study, the United Kingdom group published a paper looking at early fibrinogen concentrate in their trauma patient population, suggesting that the early delivery of fibrinogen concentrate was not feasible and could not be delivered rapidly within 45 minutes of admission. So if you can't deliver your fibrinogen concentrate within 45 minutes of admission, it probably negates the potential positive effects of early supplemental fibrinogen replacement. One thing I'd just like to draw your attention to with both these trials is that these were randomized controlled placebo trials. So that added an extra step into the delivery of the fibrinogen concentrate, as all vials were masked to all the treating clinicians and took a significant amount of time to draw up the intervention to ensure that they remain placebo-controlled trials. So potentially the time would have been quicker to delivery of fibrinogen concentrate had it not been a placebo-controlled trial. Our observational data that we've looked at suggests that we can replace fibrinogen within about 25 minutes in our institution, 25 minutes from arrival in the trauma unit, not from availability of the test. And as I said before, our patients have their coagulation status assessed by viscoelastic testing at time of arrival, and as soon as that result is available, it is then acted upon. This observational data for us was the basis of our fibrinogen study. Now, this is slightly different to the Canadian and the UK studies. We weren't assessing a finite time to delivery of fibrinogen concentrate. We were comparing the time to delivery of fibrinogen concentrate to cryoprecipitate. Specifically, we used ROTEM to guide our fibrinogen supplementation, and we only treated patients either with FC or with cryo if there was documented evidence of hypofibrinogenemia. We're very fortunate that all 4 major trauma centres in Queensland participated in this trial, and we rapidly recruited within 8 to 9 months of commencing enrolment in the study. The hypothesis was that fibrinogen replacement in severe trauma can be achieved quicker using FC compared to cryoprecipitate. As I said, this was a pilot study and did not have patient-centered outcomes as statistically significant outcomes. What we demonstrated in this trial, that fibrinogen concentrate could be delivered from time of blood draw. So the patient arrived in the trauma unit, they had their blood drawn as soon as feasible. From time of blood draw, fibrinogen concentrate could be administered within 29 minutes in comparison to 60 minutes. So a median time advantage of 31 minutes, and statistically significant quicker to deliver fibrinogen concentrate compared to cryoprecipitate. And as you can see that from the Kaplan-Meier curve, there's clear separation in the time to delivery of fibrinogen supplementation using FC compared to cryo. I'm going to talk a little bit more about that later, but I thought I would just talk about a couple of our cases that we've had at the Gold Coast in the not too distant past, just to identify and highlight how we use our algorithm. So this was a 40-year-old male who was swimming or surfing in northern New South Wales when he was attacked by a shark. He had very significant lower limb injuries and was pulled from the surf by his colleagues, and a tourniquet was applied to his upper thigh. That picture just shows you where he was attacked, just outside Byron Bay, a very popular spot in northern New South Wales. He was profoundly shocked on arrival of pre-hospital clinicians. He was intubated and ventilated. Tranexamic acid was administered along with pre-hospital packed red blood cells. We don't have the facility currently in our aeromedical retrieval to have blood product transfusion beyond packed red blood cells. And as you can see, it's about a 20-minute flight from Byron Bay, or an hour and 16 minutes by road to the nearest trauma centre, which is the Gold Coast University Hospital. So he was very rapidly transported and was a red blanket to the operating theatre. And this is actually a picture of his leg, and very kindly he's allowed us to use a picture of his surfboard that was actually bitten by the shark. So he was profoundly acidemic, and then we had pre-hospital notification, and he was red blanket from the helipad to the operating theatre. And as you can see, on arrival into the operating theatre, his FibTem A5 is 8 millimeters. His XTem A5 is 90 millimeters, suggesting fibrinogen deficiency and possibly platelet transfusion, deficiency. During the time course of his resuscitation, we repeated his ROTEM tests either after every 4 rounds of packed red blood cells or after a therapeutic intervention. And as you can see, over the time course of his resuscitation, which included several units of packed red blood cells, it was 8 grams of fibrinogen and 1 pool of platelets. And I think I'd just like to draw your attention to the clotting time on the graphs below. The XTem clotting time was never prolonged beyond the normal range. So at no stage did he require or receive any plasma or prothrombin complex based products in his resuscitation, which would have been very different if he'd had a fixed ratio major hemorrhage protocol, which would have empirically delivered him fresh frozen plasma as part of his resuscitation. I've just got one more case, if you don't mind. This is a young gentleman who was driving a bobcat. Most people in Australia will know what a bobcat is. He crashed it down an embankment and got trapped underneath it. It was neurologically intact, and you can see how far the bobcat has fallen and has trapped him underneath the bobcat. He had a fairly significant extraction time and was intubated due to agitation, hypoxia. He had obvious thoracoabdominal pelvic injuries. Again, rapid transport to a trauma unit with pre-hospital tranexamic acid and packed red blood cells. And again, very similar to the shark case that I showed, that this gentleman was profoundly hypofibrinogenemic throughout the time course of resuscitation, with also reduced platelet contribution to clot strength, requiring significant fibrinogen and platelet transfusion, but no requirement for plasma or prothrombin complex concentrate. After damage control surgery was performed, both abdominally and pelvically, and his orthopedic injuries ex-fixed, he was transferred to the intensive care unit. Unfortunately, in the intensive care unit, he continued to become hemodynamically unstable. He had a further attention pneumothorax, and then subsequently, despite further volume transfusion and a trip to the CT scan to potentially identify any further sites of active arterial bleeding, became even more hypotensive, and echocardiography demonstrated a cardiac tamponade. I'm just going to show you a picture of his CT scan. This was from the operating theatre to the ICU prior to arrival, and it clearly shows a very significant pulmonary contusion, ongoing pneumothoraces, and densely consolidated contused lungs despite the presence of intercostal catheters. No obvious cardiac injury was identified. A tamponade was evacuated and the hemodynamics were restored. There was diffuse pulmonary hemorrhage, and the lungs just looked like tissue paper at stenotomy. Bronchoscopy was performed with no major tracheobronchial injury, but very, very significantly lacerated and densely contused lungs. And we were completely unable to close his sternum due to the damage to his lungs. So at that stage, his hemorrhagic shock has been corrected, but he's now potentially dying of hypoxemic and unventilatable respiratory failure. So at about 10 hours post massive transfusion and major trauma laparotomy, we made a decision to institute rescue VV ECMO. And despite having received over 15 units of packed red blood cells using our ROTEM guided transfusion algorithm, his coagulation factors were entirely normal prior to cannulation. And we even gave him a 5,000 unit bolus of heparin directly after cannulation. So in total, pre-ECMO, we had 15 units of packed cells, 9 grams of fibrinogen concentrate, and 2 bags of platelets, a completely uneventful cannulation and no further bleeding. This is his chest X-ray again, showing the densely contused lungs and the ongoing pneumothoraces. And just at the bottom of the corner, you can see a VV return ECMO catheter. One of the things I'd like to draw attention to with this particular gentleman is, though, despite having a massive injury and life-threatening hemorrhage and life-threatening respiratory failure, due to the dedication of our team at GCUH and with the support of the Patch and the FIRESEA trial, this gentleman was still enrolled into both trauma trials. And I think we have to understand that if we're going to be investigating these patients, we have a debt of gratitude to our research staff and our patients for allowing us to enroll them into research studies. He had a relatively uneventful ECMO run. We didn't anticoagulate him for 3 or 4 days, and he had 14 days on ECMO prior to lung recovery. Our ECMO patients receive a ROTEM done every day to guide their coagulation status, specifically with respect to fibrinogen and platelet transfusion. And just prior to decannulation on our routine ROTEM test, you can see we had quite a markedly abnormal ROTEM analysis, with suggesting hypofibrinogenemia, a prolonged extem clotting time, and fairly significant fibrinolysis. This wasn't particularly borne out in the coagulation studies, which suggested that the INR was only very slightly elevated. Having said that, as you can see, the D dimer is very, very elevated down the bottom there. And one of the things that we've learned from our ECMO patients is that when they start to develop hypofibrinogenemia on their ROTEM test, that is a significant indication that there is potential circuit or clotting issues or ongoing factor consumption in the circuit, potentially necessitating a circuit change. The circuit looked okay and there was no obvious hemolysis. So what are we going to do? He's hypofibrinogenemic, he's got a long extem clotting time, he's got fibrinolysis, but we're about to remove an enormous catheter from a femoral vein. Although compressible, the 25 French is a very big hole. So what we decided to do in this particular case was just prior to decannulation, treat his hypofibrinogenemia and his hyperfibrinolysis with tranexamic acid and fibrinogen concentrate, remove the catheters. There was no further bleeding, and there was almost a total correction of his ROTEM analysis day one post decannulation. And again, I think we use this to demonstrate that we can use our ROTEM tests again to very, very closely and clearly define what the deficit is, what we should treat, and avoid unnecessary interventions in patients that could be detrimental. And that's Paul. He's the young gentleman that I just showed the pictures of. He's very kindly agreed to let me share that picture with him. He underwent one further surgical procedure prior to discharge from the ICU, which was the removal of that man bun. But he's now made a full recovery in the community. So we have a debt of gratitude to our patients. My final slide is a follow-on from the Feisty pilot study that I showed earlier, demonstrating that we can definitively give fibrinogen concentrate quicker than cryoprecipitate, but we don't know if there are any clinically meaningful benefits to giving rapid fibrinogen supplementation in terms of FC compared to cryoprecipitate. With this in mind, we've designed a phase 3 multi-center randomized control trial, which we're hoping to perform in Australia. The hypothesis being in that patients with severe trauma and hypofibrinogenemia, the transfusion of fibrinogen concentrate is superior to cryoprecipitate in terms of days alive and out of hospital at 90 days. This is a surrogate marker because mortality is a very, very difficult endpoint to demonstrate in trauma trials, especially using a single intervention. You require many, many, many thousands of patients to demonstrate a mortality benefit, which is not logistically or feasibly possible to perform. So we thought about what would patients like if they have suffered severe trauma. I think if I'd suffered severe trauma, I'd want to be alive and I'd want to be at home. And I want to be relatively free from disability. So we've picked this as a patient-centered outcome with clinically meaningful benefit to the patients. If you've had your severe trauma, you've got better, and you're at home, that is an important clinical outcome. It's going to be managed by the Australian New Zealand Intensive Care Research Centre at Monash University under the directorship of Jamie Cooper. And we have currently submitted applications to the MRFF and the NHMRC for funding. We'll hopefully hear back in the next 3 months, and we would be very interested for any trauma centres in Australia to join us in this trial. And on that note, I think I will stop talking.
Thank you so much, Dr. Winnerls. That was a really excellent presentation. And I will now hand over to Dr. Gorlinger. Thank you so much.
I just need that James is giving me the right to share the screen.
Have I stopped?
That means that, yeah, you just have to stop and that I'm allowed to share. Justin, now it works already. Fine. Okay, thanks. So I hope you can see my screen.
Yes, we can.
Yes. Okay, fine. Yeah. Thanks a lot for the nice presentation. And more or less, I start where James ended, and that was the one comment that it's not easy in a relatively small study to show significant reduction in mortality. Maggie already introduced me, and I just want to add the lowest 2 points here, which is very important, of course, for my conflict of interest. And the first one is that since July 2012, I'm the global medical director of ROTEM Innovations. The company is producing the ROTEM device. And the second one, that I was also a member of the Thai Tactic Collaborators Group. And I will discuss a little bit about the interpretation of the results of the iTactic study. And James mentioned already that this is not just started, or the story, sorry, just one back. The story did not just start 3-4 years ago. This is more or less a longer journey. And he already showed some results of the studies from Karin Broe's group from London. And one key point is that about 10 years ago, they published that acute traumatic coagulopathy is at best functionally characterized by a reduction of clot strength or clot firmness, which was here defined in their analysis as an XTEM A5 below 35 millimeters, because this predicted bleeding and in particular the need for massive transfusion in the trauma setting. And that made me start already with the first poll question. So what is the incidence, or what do you think is the incidence of trauma-induced coagulopathy in patients with severe trauma defined as an ISS over higher than 15 at emergency room admission? So is this 100%, 75%, 50%, 25%, or just 10%? So here we see the first poll question, and you can just enter what you think is the adequate answer. And then after 30 seconds, we will see the results of this first poll question. So now we see the results, and the majority of the audience is thinking that in about 75% of the patient population, you see a trauma-induced coagulopathy. And this is not a big surprise, but it's unfortunately not the correct answer, because it's only 25%. And this is based on several trials, and it's even decreasing. So we're going back maybe about 10 years, where in Germany, we were the world champion of pre-hospital volume resuscitation. We were giving trauma patients already in the emergency car 2, 3, 4 liters of volume. Yes, there was a higher incidence by being more restrictive, even in severe trauma, in between, even below 20%. So that means starting with a 1-to-1-to-1 or whatever ratio-based approach, we have to consider that we give in about 75% of the patients blood products which might not be needed. So we will discuss this later, because that was also important for the study. Just move to the next slide. Then it was also, just move this, sorry. This group, which also later on performed the tactic and iTactic study, were also looking at, even within Europe, on the diversity of clinical management and protocols used, because there were some centers, in particular in the Scandinavian area, using as a baseline a ratio-based approach, and then adding a tech-driven protocol to that. And we know that, of course, with the tech, the turnaround time is a little bit longer, because they don't have early clot firmness amplitudes available. And there were other groups from UK as well as from Amsterdam and Cologne, which used a ROTEM guided approach. And of course, there was a lot of discussion. What would be the best design for a study? And just introduce more or less the team. On the left side, you see the team ROTEM with Karin Broe from London, with Simon Stanworth and Nicola Curry from Oxford, with Nicole Ufermans from Amsterdam, and Mark Mögele from Cologne, just to show the more or less the leaders of the team. And on the right side, we have Tina Gardner from Oslo and Pa Johansen from Copenhagen. And again, one big discussion was, during the planning of the study, was about this: should we use a baseline 1-to-1-to-1 transfusion and then just use tech or ROTEM for additional therapy? or should we do it in a, let's say, pure way and just use the viscoelastic testing results? But at least the group from Scandinavia, was very keen that we have to give a baseline transfusion, because at least with attack, it takes some time that you can start your resuscitation. And in a randomized trial, you have an additional issue that you first have to wait for inclusion of the patient into the study, and that would result in additional delay. Also at that time, they looked what is already implemented, and you see that point of care testing at that time was implemented in 50% of the study sites, which was Copenhagen with TAC, and it was in London with ROTEM, and in Cologne with ROTEM. And what we see here is just what was the algorithm used at that time for ROTEM in Cologne. But of course, this was more based on expert opinion rather than really evidence. And also then there was first observational study that was ATSIT and TACTIC before we could start the ITACTIC study, which was the interventional RCT. This is the algorithm which has been developed, and you see there's a lot of data behind. So to develop this algorithm for standard lab tests, TAC and ROTEM, was based on more than 3,000 patients in an observational trial, so a little bit more than 2,200 in the ROTEM group in the 4 centers, and in the 2 TAC centers, nearly 1,000 patients in the TAC group. So that means it's not just copy paste from other algorithms. It's really based on ROC curve analysis to define the best cutoff. What we see, there is some, let's say, quality difference in particular in the functional fibrinogen testing, because you see the number more or less doubles from 10 millimeters in ROTEM to 20 millimeters in TAC. And that just shows that the platelet inhibition is quite incomplete in the functional fibrinogen assay, because it's only using a GP2B3 receptor antagonist, where the FibTem is using citrullin D, and we just moving to a combination of both, which even reduces the platelet noise in addition. That doesn't make so much difference in the trauma setting, but if we talk, for example, about COVID-19 patient with very high platelet counts, then again, it makes a big difference. So James was already guiding you through this protocol, and it just to know, okay, there was a lot of work already before the ITACTIC study started to develop these structured algorithms. Just one additional question, which is even not covered in my presentation, also not James' presentation, but maybe it's quite interesting when we ask which ROTEM assay is most sensitive for hyperfibrinolysis. Is that the XTEM, the FibTem, the UPTEM, the INTEM, or the HEPTEM test? So we have the second poll question, and 30 seconds again for you to answer, and we'll see what will be your opinion. Yeah, that's interesting. I'm a little bit surprised, in positive way surprised, because yes, you are right. You know, there was a long discussion about the sensitivity of viscoelastic testing, even also from Karen Broe's group, who said, yeah, maybe it's not sensitive enough. Now in the last years, we have several studies from different sites, from Denver, from the Moore group, as well as from Pittsburgh, and also from the Asian area. And all the studies show that FibTem is the most sensitive test to hyperfibrinolysis. So you see already an effect when XTEM looks quite still normal. And actually, we are looking even at the other side, and this is hypophospholysis when we look, for example, at COVID-19 patients. But this is, of course, a different story. So you're completely right. And I think that's a point we should move in protocols when we look at low grade of lysis more to the FIB-10 and not so much to the XTEM anymore. Okay, now really going into the field of the ITACTIC publication. And James mentioned already, just looking at the abstract, it's at the first view, it's a little bit disappointing because the message you get there is no reduction in mortality. And we have to say that really the reviewers from intensive care medicine was quite really hardliners. So if you don't show really a p-value below 0.05, you were not even allowed to mention. And you also see that even the secondary endpoint with the predefined subgroup analysis was not allowed to be reported in the papers, only mentioned in the supplement. But I think it will be maybe quite interesting. But it's important to understand the design of the study, also to do a right interpretation of the results. So the aim of the study was to perform a randomized control trial, and you have a major hemorrhagic protocol, and viscoelastic testing was used on top of the ratio-based protocol to give additional interventions based on conventional coagulation test on one arm or viscoelastic testing on the other arm. It was not designed to compare a ratio-based concept versus a goal-directed concept. And that's also very important. In this study, the viscoelastic testing was not used to stop a ratio-based approach in the case you don't show any coagulopathy. So again, it was only used to give additional medication, but not to stop maybe inappropriate medication. And I think this is a very important point to understand. Also in this study, they didn't use the viscoelastic definition of trauma-induced coagulopathy because viscoelastic testing was not done in all cases, but since standard coagulation tests were done in all cases, they used the PT ratio higher than 1.2 just to define the patient was coagulopathic as baseline or not. And again, then in the patient they recruited for the study, and we will see the inclusion criteria. Again, they used a standard test algorithm or viscoelastic testing algorithms to trigger additional administration of platelets, fibrinogen, plasma, and antipholytic therapy. And again, ratio-based blood transfusion was not stopped based on showing no coagulopathy in viscoelastic testing. So inclusion criteria, to keep it as pragmatic as possible, was that patients were involved in if they are a trauma patient with a significant injury suspected of having hemorrhage and requiring at least 1 unit of red blood cell transfusion. So it was more or less a clinical identification of the patients. And again, at least there was a request to transfuse 1 unit of red blood cells. If there was no transfusion at all, the patients were not included in the study. James mentioned already very nicely that, of course, we know from a lot of studies, it's important to treat coagulopathy as soon as possible, at least in the golden hour of shock. If we just count the admission to a hospital, and that the first intervention should be done already in the first hour. This was not possible in this randomized trial because it's always an issue if you have to randomize, and they even put a limit that you could only recruit patients if they were randomized within 3 hours of injury or at a maximum after 1 hour after hospital admission. But that means that most patients were not treated already in the golden hour of shock. And this can, of course, have an impact on the effect size, because we have seen from James' data, and we also see some data from Center TBI trial in Europe, that it is feasible to run a ROTEM and to do a therapy with factor concentrates already in the first hour. But this was not possible to the logistics of the study in the ITARCTIC trial. So it was, I think, a little bit also influenced from the US proper trial that showed this quite discrimination between patients very early to say, okay, let's use as a primary outcome the proportion of subjects who at 24 hours after injury were alive and free of massive transfusion. So as a primary endpoint, a quite early primary outcome was used. And the secondary outcome was 28 days mortality. Now you can discuss, and I think also James mentioned, what is the aim personally for you is going home and having at best no disability. Of course, it's nice to survive the first 24 hours, but in the end, I think 28 days mortality might be more important. But in designing a study, we have to do a decision. And the decision was made, okay, looking at the 24 hours as the primary endpoint, which is very important finally for the publication. And of course, we were also thinking about pre-specified subgroups. So it's not about cherry picking. That was already defined before starting the study and already published in 2017. And two of the predefined subgroups, one was there a coagulopathy defined as a PET ratio more than 1.2 at baseline? And the second, did the patient have a severe traumatic brain injury? And that time, even we were not thinking that maybe you can have a big advantage, because usually people think, okay, if you have already a damage to the brain, that might be the limiting factor. And by better management, maybe you don't change a lot in outcome here. And another more or less a safety outcome was the secondary outcome of the proportion of patients with symptomatic thromboembolic events. Because, you know, there's a never-ending idea that giving factor concentrates might increase thromboembolic complications. But in contrast, a lot of studies, in particular from cardiovascular studies, just show the opposite. So if you guide factor concentrates, and that is a precondition with viscoelastic testing, most studies showed a significant reduction in thromboembolic complications. So coming to the results and discussion, overall, the study was designed, or there was a power analysis done, which resulted in 396 patients. 201 were allocated to the viscoelastic testing group, 195 to the conventional coagulation test guided group. There were, of course, due to the delay of recruitment, several patients already get red blood cell transfusion, and even 9 patients already received massive transfusion before the patient were randomized, which means, okay, it's very difficult to avoid massive transfusion when this was already done before including the patient in the study. A very important point is that nearly 3/4 of the patients were not coagulopathic at baseline, which is not a big surprise, because we know this from the German Trauma Register and other studies, that even with an ISS higher than 50, it's usually only about 25%. And for those patients who never developed a coagulopathy, it is not unsurprising that coagulation monitoring did not alter the clinical outcome, in particular, if you don't use viscoelastic testing to stop an inappropriate ratio-based transfusion. And that is just important to keep this in mind. So we come to the third poll question: which trauma patient population does not directly benefit from a ROTEM-guided bleeding management? Is that A, patients with severe traumatic brain injury, B, patients with trauma-induced coagulopathy, C, patients without trauma-induced coagulopathy, D, patients at high risk of massive transfusion, or E, patients with anticoagulant therapy. So we have again 30 seconds for your answers. And here we are, and I agree with at least 1/3 that if there is no trauma-induced coagulopathy, there might be a benefit if we stop it, but therefore I mentioned directly benefit. But of course, in this patient population, we have the lowest chance to do some improvement, because in principle, the patient needs maybe a suture, a clip, a compression, but not the administration of blood products or hemostatic drugs. The first answer, that was what we thought some years ago, that maybe there's not so much benefit. We will see what was really the result of the study. Anticoagulant therapy, yes, there's some benefit also. The study showed not a significant improvement in mortality, but there was a signal that we can maybe identify also the patient with anticoagulation earlier. So just continuing. So what were the results of this study? This is not the primary endpoint. That's just what we could see also, like in the feisty trial, that even if we had this delay of about 1 hour due to randomization, still the viscoelastic group was about 21 minutes earlier with the results compared to the standard coagulation test, which just means that they were even quite fast with the standard coagulation tests. I think in James' study was about half an hour, 40 minutes. And the other point was that even viscoelastic testing identified more patients with trauma-induced coagulopathy, because we are not only looking at the clotting times, we're also looking at clot firmness. And that might be even sometimes a more important part of trauma-induced coagulopathy. Unfortunately, this is not mentioned in the paper at all. You have to look at the electronic supplementary material to get this information. So going back to the proper trial, does that make a difference? And even when you just use a look at the proper trial, they show that every 15 minutes decrease in time to hemostasis was associated with decreased 30-day mortality. It's not a big signal, it's just about 3%. But yeah, having faster the results and faster the therapy, also even in the ratio-based studies show an advantage without any increase again of venous thromboembolism, which was exactly the same or just maybe even 1% less. When we look at the primary endpoint, and this is of course what we have to focus because that was defined as the primary endpoint, so it's 24 hours and the proportion of patients who are alive and free of massive transfusion, the odds ratio.
Girl called who?
Hello?
Bonnie.
We have just somebody also with unmuted phone. Okay, thanks. We see, yes, it was not significant, but when we here look at the odds ratio, we have to understand here it's survival and freedom of massive transfusion. There was some improvement of about 15%, but it didn't reach statistically significantly. So it's completely correct to say, yes, the study did not show a significant reduction. If we look at the pre-specified subgroups, it's quite interesting that in the subgroup with severe traumatic brain injury, we double survival, but it's still not significant. So we have to say, maybe due to the low incidence of coagulopathy, only 25%, the study seems to be underpowered even if we have a doubling of survival and avoidance of massive transfusion, that this doesn't get statistically significant. And that's just the figure 2 from the original paper. And we see that here in severe traumatic brain injury, yes, it still crosses the 1 line, so it's not significant, but the p-value is 0.148, and the odds ratio is higher than 2. So it's quite a strong signal, again, which is not significant. And if we look at the non-traumatic brain injury patients, there is no difference. And if we look at overall study population, there is a trend, but again, it's not significant. There is a 15% higher survival, which is just from the effect size not too bad, but we need a bigger trial to show that this really has a significant impact on 24-hour survival and freedom of massive transfusion. As I mentioned, secondary endpoint was 28 days mortality overall. Here we're looking now at mortality, so it just goes to the other direction, but quite similar. We have an odds ratio of 0.84, so something about 15% reduction in mortality. Not all patients were exactly treated per protocol, so you have also not 100% adhesion to the protocol. And when we look at the mortality per protocol, even the difference gets bigger, so about 23% difference, but it's still not significant for 28 days mortality. One interesting part is looking at, again, the pre-specified subgroups also for the secondary endpoint. And then we see that the difference for 20 days mortality in severe TBI is an odds ratio of 0.28, which is, from my point of view, very impressive and even highly significant. So that means in severe traumatic brain injury, you can save between 2/3 and 3/4 of the patients by an early administration of viscoelastic testing guided therapy. But unfortunately, again, also all the results for subgroup analysis of the secondary endpoint, you will not find in the manuscript. These data only presented in the electronic supplementary material. So from my experience, a lot of people reading the abstract, some people reading the full-size paper, but nearly nobody is reading the electronic supplemental material. But I think really in this study, it's very interesting data just presented there. And this is about a 50 pages document. So when we look here at the supplementary figure 1, looking at 28 days mortality, we see already when we look at coagulopathic or not coagulopathic patients at baseline, so at admission to the hospital or at inclusion into the trial, defined as a PT ratio of more than 1.2, there is already a nearly 50% reduction in mortality in the coagulopathic patients, which again doesn't reach statistical significance. P-value is 0.07, so it's just not statistically significant. But of course, here we have only 100 patients from the 400, which were included in this subgroup analysis. And it's not a big surprise that the non-coagulopathic patients doesn't benefit from any additional therapy. They might even benefit from less therapy. And when we look again at the subgroup with severe traumatic brain injury, we see this highly significant separation that the patient with severe traumatic brain injury had a significant reduction in 28 days mortality with an odds ratio of 0.28 and a p-value of 0.016. So I think at least the ITACTIC study can show us what is the subgroup or what is the patient population in trauma which benefits most. And when you also see here, it's again not significant, but there is a strong trend even also for anticoagulant patients that they might have a benefit. We can identify this anticoagulation early. Anyway, if we just look at the overall study population, including the 75% patient with no coagulopathy, there is still a reduction in mortality for 28 days, about 26%. But again, this is not statistically significant. And we would need maybe a 4 times bigger patient population to show significant results here. So when we look at the results, there is not only with iTactic, also with other studies, a growing body of evidence that in particular in patients with traumatic brain injury, there seems to be a big advantage in using viscoelastic testing as early as possible, for example, to avoid a hematoma growth in this patient population. And as I mentioned, there are additional studies. At the same time, when the iTactic study was supported by the European Union, there was also the Center TBI study, also a very huge, mainly observational study to learn about traumatic brain injury. But we also had the possibility to run a small study, interventional trial. But since we were aware that this patient population, which we were able to include, is not huge enough to show results on outcome, it was more like an implementation study. So we were only including here study sites from Center TBI, never used the ROTEM before, implemented ROTEM with the ROTEM Sigma system, and trained them to use a standardized protocol to do the therapeutic intervention. And what we measured were turnaround times and adhesion to the protocol. And what we see here is not a big surprise. James showed this, the iTactic study showed this, that using viscoelastic testing here with the ROTEM Sigma, you have an advantage in turnaround time from about 40 minutes, 33 minutes, that's the time from admission, hospital admission, not from blood sampling, compared to 70 minutes in standard coagulation tests. If we just look at the time after blood sampling, it was quite narrow, 15 minutes in mean, with a range of 10 to 19 minutes that ROTEM results were available after blood sampling, which is again 40 minutes longer for standard coagulation tests. The next one, I think, or here the next one is very important, how quick decisions are made. And I think that's very important, training the emergency room staff to use an algorithm. And you see that was only 9 minutes between having Sigma results available and the therapy with factor concentrates were done. And of course, this is impossible with plasma or with cryoprecipitate, and even with platelets. You can only do this with factor concentrates, that the therapy is done with a little bit less than 10 minutes after having the results available. This was a protocol, looks quite close to the protocol also used in iTactic, just with a difference. There was no baseline transfusion of plasma or platelets. If there was no coagulopathy, and that's here, 4 times no, means no intervention is done. And you see the adherence to the protocol was always between 87.5% up to a little bit more than 90%. So that's also important. If the algorithm is too complex, maybe adherence is low. So we have to keep it as simple as possible, but we clearly have to define when to give which intervention, and in this study to avoid any intervention which has not a clear indication. And that has also been used in between in our interventional trial. It was not a randomized trial, but here also they showed, and very close to the Center TBI trial, an adherence to the protocol of about 85%. And as clinical endpoints, because also this study was too small for mortality, but they looked for the progression of hemorrhagic injury, which is one of the most feared complications, and this dropped down from 48 to 30%, and the need for neurosurgical reintervention because of ongoing bleeding, which was reduced from 40 to 13%. So this was a significant in favor for a ROTEM guided approach. And also they could show and concluded that the implementation of a ROTEM based protocol leads to a consistent management. So not everybody invents the wheel every day again, improved quad quality and decreased incidence of progression of hemorrhage and the need for neurosurgical reintervention in patients with isolated traumatic brain injury. So that's in line what we see with the iTactic study. When we look again at the signals, of course, first of all, we have to say the change in 28 days mortality overall, and also in the patients with trauma-induced coagulopathy defined as a PT ratio of more than 1.2 was not significant, p-value 0.07, but I think the effect size quite impressive, which means nearly a 50% reduction in mortality. So the question is, you can always discuss, the hardliners will tell you, okay, you are not allowed to report this because it was not significant. Or you can say from a clinical point of view, oh, the effect size is very impressive, so maybe the study was underpowered. And we can only answer this question with a new study or with meta-analysis, combining different studies. But I think this, the point is quite strong that if we see that only 25–26% were coagulopathic, to have a higher number of coagulopathic patients, I just did a post hoc power analysis, which result that we would need the same number in the study, but if we only include coagulopathic patients, as it has been done in the RETIC trial, the result might have been significant, but might have been doesn't really help. Again, this is not a big surprise or a wrong recruitment in the study. These are the data from the German trauma register from 11 years, is more than 200,000 trauma patients, and it just shows again, yes, that's true, that only 1/4 of trauma patients at admission to the emergency room are coagulopathic. And that, I think, is also important information, because usually nowadays we use ROTEM algorithms, as I called, as a not to do protocols. If they're not coagulopathic, maybe it's a better idea not to transfuse plasma and platelets. And also the randomized trial from Ernest Moore showed that they could improve mortality with less blood transfusion. Another endpoint, secondary endpoint for safety, you will not find in the main paper, only again in the supplement, is the incidence of symptomatic thromboembolic events. And I think actually at the time of COVID-19, we know thrombosis is also very important. And what we see is, again, p-value is not significant, it's 0.088. But again, I think effect size quite impressive, which means 40% or more than 40% reduction of thromboembolic complications. So to have some reduction in mortality and as safety, less thromboembolic complications, I think quite interesting. I said that we see the same in the RETIC trial. Here, the odds ratio for thrombosis was 0.44, also just as the single randomized trial, not significant, but quite interesting if you take together the data from the RETIC trial and the iTactic trial for thromboembolic complications, odds ratios again 0.53, and it's also significant. So that's just showing this data. And the point is, yeah, quite often we see, just looking at one RCT, that, yeah, we don't see already a significant results. And I think that's the reason why we do meta-analysis, combining studies, and here combining 2 RCTs. So for me, at least, it shows there seems to be some advantage on survival, but also a safety signal, which is definitely not what all the people are repeating again and again. Using factor concentrates might increase thrombosis. Also in trauma, like in cardiovascular surgery, showing it's the opposite. Guiding factor concentrates with viscoelastic testing seems to reduce the incidence of thromboembolic complications. So just summarizing the limitations of the iTactic study, and of course every study has limitations. The first limitation might be that, of course, and that will happen again and again in randomized trials, if you have to do randomization after admission to hospital, there's always some delay. It was limited in the iTactic study to 1 hour after admission to hospital, but we know this might be really the most important hour for decision making in trauma. So even this delay might have an impact on the efficiency or additional benefits of viscoelastic testing compared to just cohort studies where you start immediately after admission to hospital with starting a viscoelastic testing. And as the Center TBI trial showed, it is feasible to even perform the first therapeutic intervention based on viscoelastic testing within 1 hour after hospital admission. So that might, again, have an impact on the effect size and is not in line what is recommended in the European trauma guidelines, where they say, okay, you should start immediately with monitoring. But yeah, that's just an issue of randomized trials. The other point is definitely that all the patients get a ratio-based blood transfusion, and this was continued even if viscoelastic testing or standard coagulation test did not show any trauma-induced coagulopathy. That was a long discussion between the, let's say, German and Netherlands group on the one hand and the Scandinavian group on the other hand, that usually in Germany we try even not to start a ratio-based transfusion, where this is more or less standard of care in Copenhagen and also in Denmark and in Norway, maybe because it takes a little bit longer time to get clot firmness results on the TAC. But I think this is a quite important limitation, that we use the protocol as an do on top protocol and not to avoid what is not needed protocol. And there are some data available, and this is already published from the group from Mark Megley in 2019, looking at all the studies about platelet transfusion in traumatic brain injury. And there's only one study who's showing some benefit. Overall, when you pool the data, there is a 50% increase in issues by early platelet transfusion, even in traumatic brain injury. So that means it's not always more is more, maybe less is more. So again, the effect size might even be better using a not to do protocol. The other point was that I think also James mentioned this already. In Germany, it's at least standard of care using ROTEM if you have an isolated prolongation of the extent clotting time, not to use plasma anymore, to use 4-factor PCC, which was not allowed in the study protocol. So you had to use plasma, which we know has a much less effect size if really the enzymatic factors are missing. Since that was not standard of care and more or less not allowed in UK, we had to agree to have the same protocol that PCC was not allowed to use. So also additional limitation. And it might be a little bit funny that even in the US in between, there was a study published using 4-factor PCC in trauma, here again on top of fresh frozen plasma. In Germany, we would say instead of fresh frozen plasma. But even if you use it on top, there was a significant reduction in mortality from 28 to 18%. And interestingly, a lower rate of acute respiratory distress syndrome from 4.7 to 1.3, less acute kidney injury from 7.3 to 2.2, and a lower, not significantly lower, but nearly 50% lower again, incidence of deep vein thrombosis from 5.5 to 3.4. But still, a lot of people continue to say, factor concentrates might be associated with more thrombosis, but all the study showing the opposite. Again, one very important limitation is that only 1/4 were showing a coagulopathy. So I think it is definitely underpowered to show this significant reduction in mortality. Yeah, but it is as it is, so we have to keep the data as they are, but it still more or less fits to what we saw in other randomized trials or interventional trials, that we compare the odds ratio or the risk ratio more or less also other studies come to the same result, that the odds ratio or risk ratio is between 0.7 and 0.8. That was also the reason that just recently in December, the Eastern Association for the Surgery of Trauma in the US published new guidelines where they clearly recommend the use of viscoelastic testing, because they also did a meta-analysis based on 1,500 patients, which showed again a relative risk for mortality of 0.75. You remember it was 0.77 for the iTactic study, and in the meta-analysis without including the iTactic study, this was already significant. So that is what was published in December. I don't know exactly how they selected these studies. It's a mixture of randomized and cohort studies. Again, I don't know why they just selected these 6 trials, but you see, okay, here is already a quite significant, with a p-value of 0.02, reduction in mortality, again with a risk ratio of 0.75. And this was not only shown in civil trauma. Of course, in the US, quite closely look at military trauma. And there are now 2 studies published. And one study is just published also in December, more than 3,000 military trauma patients from Afghanistan. And you see again, risk ratio 0.69, so very close to the 0.7 to 0.8, and already highly significant also in trauma, and also showing a reduction in thromboembolic complications. So that is the Lammers paper published in December, where they also at least asked the question, is it time for a new standard? Showing that even with the relatively low overall mortality, they showed more or less a 40% reduction in mortality if you use viscoelastic testing for initial resuscitation of these patients. And what I did, it's not already published, but in preparation, I looked at all the studies, trauma studies, which included viscoelastic testing, and we're looking at mortality as an endpoint. And this is overall not only 6, it's 22 trials with 8,000, nearly 8,500 patients, and not a big surprise again. You see a risk ratio of 0.71, so it's always between 0.7 and 0.8. And in this huge population now, we have a p-value of 0.001175, so it's really highly significant, but it's not focused only on randomized trial. It takes together randomized and big cohort studies. So yeah, coming to more or less the last conclusions. Another, I think, very important information iTactic provides is what is really the trauma population which benefits most. And again, it's not a big surprise that the non-coagulopathic patients don't benefit if it's an add-on algorithm. They might benefit if it's a not-to-do protocol, but that was not done in the iTactic study. It's the coagulopathic trauma patients, it's a patient requiring massive transfusion, and in particular, the patient with traumatic brain injury, which benefits most. And that might be in the future to focus also on this patient population and to use viscoelastic testing early here. And that's just an infographic to a publication from 2017 in Anesthesia Analgesia. And they already mentioned here, that was the same time where the protocol from iTactic was published, that an MTP or monitoring, hemostasis monitoring, should be used to start an MTP, but it should also be used to stop an MTP if there is no coagulopathic anyway or not anymore. And I think, yeah, the future is now. The evidence is increasing. The iTactic study as a standalone study does not provide already the evidence that a viscoelastic testing guided approach is superior, but taking all the studies together, it fits very well to all the other studies, showing again a reduction for mortality, a relative risk reduction for mortality of about 25 to 30%, which has been shown again and again and again. And also it seems to be more safe by avoiding thromboembolic complications. Yeah, the story is not ended now, but I think, again, the evidence is increasing. And what we need are evidence-based protocols. They should be based on observational trials to define the cutoff values. And of course, yeah, we have to design good studies which are powered enough to show in the end a significant reduction in mortality and outcome. But again, I think I can just repeat what James said. What is important for the patient is go home and go home in a good condition. I think that's what we can do, and where I think viscoelastic testing in combination with factor concentrates and in combination with not to do algorithms can help to achieve this goal. And thank you for your attention, and we are open for discussion.
Thank you so much, Dr. Gorlinger, and Dr. Winnerls as well. Those were really wonderful presentations. I see that we have gone a bit over time, so I don't think we'll have much time to do questions or discussions at the moment, but we have advised people to please put their questions in the chat so that we can follow up with an email to be sure that all of the questions, we had a lot of really great questions and some comments come through as well. So thank you, both of you again. Do either of you have any final comments before we close the session for tonight?
Just to say thank you very much for inviting me to be part of this session. Much appreciated, and happy to answer any questions at all.
Yeah, I think also, I think what we might have learned is, yeah, we are still on the way to learn and what the best way to treat trauma patients, bleeding trauma patients. The other thing, I think it's very important to read papers very careful. Just to look at the abstract might result in, yeah, getting not the real message of the paper. It's really complex to design studies, and sometimes you are even surprised about some results. But yeah, that's the way how evidence works. You clearly have to define in advance. You cannot just do cherry picking in the end. And yeah, that means, okay, we have to design the next study. Even I think that we learn more and more, and every study can contribute to that. But yeah, we have to read them very carefully. And thank you for your attention. I'm sorry that the time for questions is more or less already over, but yeah, we will be happy to answer all the questions then also by email.
Thank you so much for that. So that concludes tonight's Emerge event. We hope you all found this meeting to be instructive and insightful. Thank you so much for taking time out of your busy evenings to join us tonight. And we really do hope to receive your feedback on the session through the survey, and look forward to seeing you at our upcoming events. So thank you again so much, Dr. Gorlinger, Dr. Winnerls. We really, really, really appreciate your time and support. We know how extremely busy both of you are. So thank you for taking time to be with us for this event and offering your expertise. Once again, I'm Maggie Harrington, and from our whole Work on Australia team, thank you so much. Stay safe and see you next time.
Bye-bye.
Thank you. Bye-bye.
Thank you. Thanks, guys. Thank you. Thank you, everyone.